Assalamu alaikum everyone. I hope you are all doing well. I'm Aisha Zulfikar, and you know that today our topic is nephrology, which will be presented by Dr. Sidrah. She has done Pharm.D, M.Phil, and BCPS with added qualification in infectious diseases, and she is currently working with Shoppers Pharmacy in Ontario, Canada. So we will start without further any delay. Ms. Sidrah, it's over to you.
Thank you very much, Ms. Aisha, and Dr. Kamran and Dr. Aslam Siddiqui. Thank you very much. So nephrology is the second topic that we will be discussing, that I will be covering, obviously. So I guess that this is also, I mean, all the BCPS lectures and topics, obviously, they are lengthy, but nephrology is one of the chapters that has a lot of calculations. So I would suggest that if we can have a calculators or kind of mobiles with us so that we can calculate if it is required, would be really helpful for us to catch up with a lot of calculations. So when I was, just a second. Okay, you guys can see the screen, right?
Yes, ma'am.
Okay, sure. So thank you. So when I was preparing this lecture, I was thinking from the point of view that if you don't have to go through the theory book, and if you can just read this lecture and be done with the chapter, that would be very nice. So I've prepared this lecture with the sense that I've covered all the patient cases that I mentioned in the chapter. So obviously there are a lot of cases in that, but since we will be discussing that and we'll be doing this live, so it will be easier to understand. And I hope that after having this lecture, you won't have to go through the theory chapter on its own. You can just go through this lecture and listen to it and do the calculations on your own, and you'll be done with it, inshallah. So I guess we should get started. So we'll start first of all with our first case. It is a 48-year-old African American. He's 70 kgs. He comes with a history of type 2 diabetes, his hypertension, osteoarthritis, admitted to ICU after an acute MI. He was initially hypotensive, required 3 liters of IV fluid. His BP is now 100/65. Medications before admission include metformin, BID, lisinopril 20 mg daily, acetaminophen every 6 hours for joint pain, and aspirin 81 mg daily. Before admission, his kidney function was normal. Before admission to the ICU, his kidney function was normal. It was his serum creatinine baseline was 1. However, during past 24 hours, his kidney function has declined. His blood urea nitrogen has popped up to 20 mg per dil. His serum creatinine has doubled. It's 2.1 now from 1. His serum sodium is 140. His potassium is 4.4. His urinary volume has been 300 mils over past 12 hours. So if you calculate by the weight, it's around 0.3 mils per kg. He's 70 kg, so it's around 0.3 mils per kg per hour in the past 12 hours through urinary catheter. His urine shows muddy casts. His urine sodium is 45 and urinary creatinine is 20 mg. He has edema and pulmonary congestion. So we actually first have to decide what stage of acute kidney injury, AKI is acute kidney injury, he is at. Is it KDIGO stage 1, stage 2, stage 3, or probably it's too early to assess? So our first topic that we will be discussing is acute kidney injury, right? So there are basically 3 markers for acute kidney injury whenever we are talking about. Just a second, I will just open this since I can't see the chat section. So I just want to have a view side by side just in case you guys have any question. So I'm just pulling it to the full screen again. And if there's a chat and I don't respond to it, I would just request you just unmute your mic and ask the question, because I can't see the chat screen right now because of the settings, right? So if you have any question and you've typed in the chat and I've not responded to it, I'd request you to unmute your mic and just stop me there. So acute kidney injury basically is assessed based on three basic markers. One is glomerular filtration rate, the other is serum creatinine, and third is urine output. So you always look at the GFR, the serum creatinine, and look at the urine output. So kidney disease initiative guidelines opportunity. Aisha, question. Yeah, thank you, Aisha. Thank you so much. So KDIGO definition says, so now we'll start to memorize how do we define acute kidney injury. Either it's a serum increase of 0.3 mg per del or more within past 48 hours, or there is increase in serum creatinine 1.5 times the baseline in the past 7 days, or the urine volume is less than 0.5 mils per kg per hour for the last 6 hours, right? So it's a constellation, a combination of all these three, either of the serum creatinine values, like it's an increase of 0.3 mg or more in the past 24 hours, or if the patient is reported late and you're monitoring it regularly, and in the past 7 days, you found out an increase of 1.5 or more from the baseline. And along with that, the urine volume has been less than 0.5 mils per kg per hour in the past 6 hours, you label that as acute kidney injury, right? So there are a number of criteria on the basis of which we classify AKI. It's the rifle classification, the KDIGO classification, and the AKIN, acute kidney injury network classification. So I'll just share what all these three are all about, and I'll just give you the crux of this. Like, obviously, it's not important according to which standard you're classifying it, but it's important to know that your patient has acute kidney injury. So based on that, it's very important to know the values. Like, for instance, according to the rifle classification, there's stages as risk, as injury, as failure. So if the serum cret is 1.5 to 2 times the baseline, and the GFR has reduced by less than 25%, and the urine output is less than 0.5 mils per kg per hour in past 6 hours, you call this as a risk for AKI. So 1.5 to 2 times. GFR decreased by less than 25%. Our patient has had around a 50% decrease. His serum cret increased from 1 to 2, right? So it's more than 50%. And 0.5 mils per kg per hour. Our patient's urine volume has been around 0.3 mils per kg per hour in the past 6 hours. The second stage is the injury. So the serum creatinine increased to 2 to 3 times above baseline, or GFR has reduced by less than 50%. It's called as the injury. And the urine output is less than 0.5 mils per kg per hour and for more than 12 hours, right? And the failure is that serum creatinine has increased by more than 3 times above baseline, or GFR is decreased by 75%, or in any case, the serum creatinine has been moved more than 4 mg per del, and there is an acute rise by more than 0.5 mg per del, right? So it's a complicated mathematical situation, but what you need to understand is 1.5 to 2 is risk, 2 to 3 is injury, and failure is more than 3 times. So you always look at the serum creatinine and look at the rise. If the rise is 1.5 to 2, think about the risk. If the rise is 2 to 3, think about injury. If the rise is more than 3, you start evaluating if it's a failure, right? Now, the important classification, which is more practical, is the KDIGO and the AKIN criteria. There's a very minor difference between the two. It's just a 0.9. It's 1.5 to 1.9 fold increase, stage 1. Stage 2 is 2 to 2.9 fold increase, and stage 3 is more than 3-fold increase for KDIGO. If you look at AKIN, it is the same. It's just 1.5 to 2, 2 to 3, and more than 3. So it's just a difference of there's an overlap. Like if you say the 2 or more than 2 is going to be a KDIGO class 2. So if you look at our patient, his urine volume has been less than 0.5 mils per kg per hour for more than 12 hours, and he has had a 2 to 2.9 fold increase in his serum creatinine. He has had a twofold increase in his serum creatinine, right? So this was the Aiken criteria. Now coming back to this case, this patient's baseline serum creatinine was 1, which got increased to 2, and his urine volume in the past 12 hours has been 300 mils. If you do the math of per kg volume, it's around 0.35. You can also calculate on your own just to memorize it better. And what, according to you, is the correct KDIGO stage for this patient? If I could have any comments. Yes, Mahnur, stage 2. Okay, very rightly said. Anybody else? So if you want to have a look, because this is like mathematical and it takes some time to absorb. So you just look at the classification that we just discussed. You don't need to be too, I don't want to be too fast just to cover everything and not make things clear. So KDIGO is 1.5 to 2. The serum creatinine rise of 1.5 to 1.9 fold is stage 1. 2 to 2.9 fold is stage 2. And you look at the 12 hours window for stage 2. This patient's urine volume has been measured for 12 hours, and we have seen a less than 0.5 mils per kg per hour. So it's very obvious that this patient's KDIGO class is stage 2. So Manu, you're very right? So this patient is a stage 2 case. Now, which best depicts this patient's FeNA, fractional excretion of sodium? So why do we calculate fractional excretion of sodium? We are looking at the capacity of the kidney to reabsorb and filter out sodium, right? So the normal range for reabsorption, the fractional excretion of sodium is 1 to 2. 1 to 2% of the sodium that is coming into the kidney should be filtered out in the urine. Any value more than that is abnormal. Any value less than that is abnormal. If the patient's fractional excretion of sodium is more than 2, that means that he's hyperfiltering it. That is, the concentration capacity, the reabsorption capacity of the kidney is impaired. There is some functional intrinsic problem with the kidney. That is why it is unable to reabsorb the sodium and is being secreted in the urine. If the value is less than 1, that means that the excretion has reduced and there is more concentration in the kidney to make up for the blood pressure or something. So if usually, as a rule of thumb, if you get a fractional excretion of sodium of less than 1, the cause of the kidney impairment is basically pre-renal. There's nothing wrong with the kidney. It's just because of the messages from the systemic circulation, the kidney has to concentrate the urine in the body. So there is less excretion of sodium out of the body. But if the value is more than 2, that means that the kidney is incapacitated to reabsorb the sodium and the excretion is more. I think it should be clear that what does FeNA mean, right? So it's very simple to calculate. We just take the urinary sodium and multiply that with serum creatinine. And you take the serum sodium and multiply that with urine creatinine. And you put the values in, and it always is reported as a percentage. And you multiply that with 100 and you get the value. So for this patient, if you just put in the values, you can see that his urinary sodium is 45, his serum creatinine is 2.1, his serum sodium is 140, and his urine creatinine is 20. And multiply that with 100, you get a 3.37%. You round it off to 3.4%. So this patient's FeNA would be, as we just calculated, and you can calculate on your own also, just to have a practice on that, because this is a really helpful information. It gives you an idea of how to calculate and how to assess the type of the acute kidney injury. It helps you classify according to that. So this patient's FeNA is 3.4%. Now, as we discussed earlier, since this patient's FeNA is 3.4%, the chances of a pre-renal injury is less, and the chances of a renal injury, renal cause of acute kidney injury, is more. Right? Now, what best depicts the classification of this patient's AKI? Is it pre-renal azotemia? Is it intrinsic renal disease? Is it post-renal obstruction, or is it functional AKI? So basically, there are three main types of acute kidney injury. The three main types of acute kidney injury. Just a second. Yeah. So one is pre-renal and functional. The other is intrinsic, and the other is post-renal. The three basic types. So either it's a pre-renal cause causing the acute kidney injury, or there's intrinsic problem with the kidney, or it's a post-renal problem. Clinical presentation usually is a volume depletion for pre-renal cause, renal arterial stenosis, congestive heart disease, hypercalcemia, right? So these are the kind of reasons behind, this is a clinical presentation. Intrinsic acute tubular necrosis or acute interstitial nephritis usually presents with long-standing renal hyperporphyria, like with nephrotoxins, with vasculitis, with glomerulonephritis. If you look at this patient's case, the patient that we were previously discussing, he was provided 3 liters of fluid. He's not volume depleted, but this patient is an acute MI case, and patients who are acute MI case or patients who have had myocardial infarction, there could be a case of long-standing renal hypoperfusion, and that could lead to an acute tubular necrosis or acute kidney injury. Post-renal causes usually present with stones, benign prostate hyperplasia, or with cancer. On physical exam, for such patients, you see hypotension, dehydration, thrombotic petechiae, or ascites. This patient does not present with dehydration. He has been provided 3 liters, and currently he's not hypotensive at all, right? Intrinsic causes may present with persistent hypotension, with rash and fever. And the post-renal causes can be a distended bladder, enlarged prostate because of the stones, because of hyperplasia, right? The important values to consider in this case is the serum blood urea nitrogen to serum creatinine ratio, right? So if it's a normal ratio, like 10 to 15 ratio 1, 10 to 15 ratio 1, it's usually intrinsic. That is that it's not pre-renal. But if the urea nitrogen is increasing disproportionately to the serum creatinine, that usually is a pre-renal cause because it's an azotemia, right? So in our patient, if you see the proportion of the bun is the increase in the bun is very proportionate to serum creatinine. I'll get back to the case since I'm referring to it time and again, it would be easier to understand. So if you look at the bun here, it's 20 and it's the serum creatinine is 2. If you look at the ratio, it will come out as around 10 to 1. So it's not a disproportionate increase in blood urea nitrogen as compared to the serum creatinine. It's a normal ratio. So more of a chance or more of a reason to consider a renal cause rather than a pre-renal cause for this patient. The urinary sodium usually is less than 20 in pre-renal, it's more than 40 in intrinsic. And we can assess why there is a higher excretion of sodium in intrinsic and post-renal cases, because these intrinsic disease and the post-renal disease, they actually deal with the functionality of the kidney or the organs after the kidney. So when the kidney's functionality is impaired, their ability to concentrate, their ability to reabsorb is reduced. So there is higher excretion of sodium in the urine. And this is the reason why you get a higher FeNA. So the FeNA value, the fractional excretion of sodium value for intrinsic as well as for post-renal disease is more than 2%. But for pre-renal cases, it is less than 1%. Our patient's FeNA was 3.34, right? So it was more than 2%. It's usually, when you look at these values, you can see that this patient is going towards an intrinsic kind of, and this patient does not have a distended bladder, right? He doesn't have stones or cancer or benign prostate hyperplasia, anything like that. There are other values also. So based on the information that we've just discussed, which is the best classification for this patient's AKI? Either it's pre-renal azotemia, intrinsic renal disease, post-renal obstruction, or functional AKI. Any ideas, please? Anyone? I'm sorry, my camera is not working. I feel more connected when I can like see at least myself. I can't see any of you guys, but there has to be somebody you're talking to. Talking to this blank screen is very irritating. I can't see the camera. There's some problem with my camera. Okay, so Rifat says C, post-renal. Mahnur says intrinsic. Rifat says C. Okay, B is correct, I guess. Rifat, B. Mahnur says two. Okay, this was the previous one. Okay, anybody else? So we'll get back to the case. So the difference, what I understand, we have been able to differentiate between the pre-renal and the intrinsic because we have ruled out pre-renal, but we aren't able to differentiate between intrinsic and post-renal. That's why we are usually getting confused between post-renal and that. So you look at the case again. So his urine shows muddy casts. His urine sodium is 45 and urinary creatinine is 20. He has edema and pulmonary congestion. There is no enlarged prostate. There's no stone. There is no benign prostate hyperplasia. There is no cancer, right? So in such conditions, you would never consider a post-renal cause. You will look at the intrinsic cause. And since this patient's values for FeNA and urinary sodium and serum bun to serum creatinine ratio rule out a pre-renal cause, his bun to serum creatinine ratio is 10:1, which falls in the intrinsic category or the post-renal category. His FeNA is more than 2%. It's not less than 1%. So we would not consider a pre-renal cause. He's not volume depleted right now. He doesn't come with hypercalcemia, right? And his WBCs and his urine sediments are showing muddy brown tubular epithelial cells. While in case of pre-renal cases or in post-renal cases, you hardly ever get a muddy brown cast or a tubular epithelial cell. So when you look at all the three scenarios, you can easily assess that this is an intrinsic renal disease. This is an intrinsic renal disease. Since the patient is not showing any symptoms of bladder stones, lithiasis, or anything, he is not showing any pre-renal causes. Everything is consistent with a renal cause. There's something inside the kidney. And the reason behind that could be a long-standing renal hyperperfusion that usually happens with patients with CHF or patients who come with MI. So this could be a possible cause. And the other causes for tubular necrosis are contrast or vasculitis or infection like glomerulonephritis. So the right option for this case in terms of the classification of AKI would be intrinsic renal disease. Now, moving on, which best depicts the medication that could potentially worsen the kidney function in this setting? So he's on a certain number of antibiotics, certain number of medications, and we want to assess what medication that he's currently taking could actually worsen the kidney function and should be discontinued at this time. Either it's lisinopril, either it's nicotine patch, either it's acetaminophen or aspirin. So Rifat says A, Zareen says D, Mahnur says D. Okay, so let's get back to the case. I guess I should have mentioned the case multiple times, but let's get back to the case. So this patient is on lisinopril, and his aspirin is 81 mg per day. His aspirin is 81 milligrams per day. His lisinopril is 20 milligrams per day. Acetaminophen is 650 milligrams every 6 hours, right? So now getting back to the question that we were discussing. So starting from D, aspirin low dose has hardly any involvement in causing or worsening tubular necrosis or kidney function. It's a very low dose. The minimum dose of aspirin that can possibly have an effect on the kidney functions is 150 mg. It's 81 mg, way lower than that, and it's in any ways a non-nephrotoxic drug, a prototype of NSAID. So that's not a possibility. Acetaminophen is doesn't cause any nephrotoxicity. It's majorly a hepatotoxic drug. It doesn't cause nephrotoxicity. And in any ways, he's taking it in a very good dose, like 650. He's not taking 1 gram. And even if it was 1 gram, this is just this is irrelevant. So acetaminophen is not the cause. Nicotine has everything to do with the liver and nothing to do with the kidney. And it's a patch, nevertheless, so not an involvement. Lisinopril, though, is a vital drug. ACE inhibitors and ARBs, angiotensin receptor blockers, though they are very vital for proteinuria, for treatment of proteinuria, and they have an active role in kidney disease, in chronic kidney disease specifically, but they're nephrotoxic. They can cause afferent vasodilation, They can actually worsen the kidney functions. So we always look at the serum creatinine. If it's a more than 30% rise in the serum creatinine after starting an ACE inhibitor, you actually hold it off. So the right option, as Maria and Zareen and सॉरी इधर ये अंग्रेजों के साथ रह रहा है कि ना सीधे नाम भी उल्टे बोलते हैं मारिया को यहाँ पे मरिया यूजुअली लोग बोल रहे होते हैं तो अपनी हमारे अपने लोगों के नाम भी मैंने बिगाड़ने शुरू कर दिए सो मारिया या A Zareen A yeah you are very right in that and we all know now that why D is not the right option because it's a low dose aspirin and it hardly has any involvement in that. Which is most appropriate to add at this time? So what would you do at this time? Either would you give IV sodium chloride 0.9%, or you'll give hydrochlorothiazide, or you'll give furosemide, or you'll do fluid restriction. What should you do at this time? So for acute kidney injury prevention, it is either you hydrate with 2 liters NS per day, you educate the patient, you avoid nephrotoxic drugs, and you give targeted drug therapy. So treatment and management of AKI basically has, for pre-renal azotemia, it's basically BBHH. So it's you manage the blood pressure, you provide blood products if that hypotension is because of hemorrhagic blood loss. So you see, usually patients with pre-renal disease are hypotensive. They're hypotensive because they are hypovolemic. So you need to look at the reason for the hypovolemia. Either it's sepsis or blood loss. What is the reason? If the hypovolemia is secondary to a blood loss, you replace the fluids with blood products also, because that is going to replenish the fluid. And you also do the hemodynamic correction. You do the crystalloids preferably and colloids if it's a hepatic cause. And you hold the toxic drugs. That's how you manage pre-renal azotemia. The intrinsic ones are usually by eliminating the causative agents. There's no specific therapy for intrinsic renal failure. You just eliminate the causative agents. And for post-renal, you relieve the obstruction. You remove the stone out and you just relieve the obstruction. So what do you think in this scenario should be the most appropriate to add? Any ideas? So the only medications that have had a role in acute kidney injury are loop diuretics. You first look at the fluid condition, like the hemodynamic stability of the patient. If the patient is hemodynamically stable, that is, enough fluid has been given to the patient, like our patient has received 3 liters of fluid already. He's not hypovolemic currently. So you do not need to think about intravenous fluid replacement or crystalloid therapy at this point in time. Hydrochlorothiazide actually in acute kidney injury of a creatinine clearance of less than 30 mils is not going to have any diuretic effect. So it's going to be ineffective. Fluid restriction is not going to do anything to this patient. There's nothing like a hypervolemia associated acute kidney injury. So there's nothing to do. Loop diuretic actually will help to deal with all the electrolyte abnormalities and would help relieve the interstitial working of the kidney. So loop diuretics actually will be very effective. So as you guys have said, option A is, sorry, anyone has given any answer? Yeah, so in any case, a very good question, Rifat. If it's a patient is hypertensive and has a chronic kidney disease, antihypertensive for this patient would be. It's a very good question, and we are going to discuss chronic kidney disease in a while, and I will definitely answer your question at that point, because we're going to touch on what drugs are to be used and what is the goal blood pressure and how do you manage that and what are the drugs. Okay, so just be with us for a while. We're going to discuss CKD. So this is actually an acute kidney injury. We are right now at acute kidney injury, and we're talking about what are the best drugs to use. So hydrochlorothiazide is going to act on the distal tubules. We need more effective working, right? And this patient would need that. So let's get back to the patient again, just to have a better idea. Yeah. So this patient currently presents to you with a serum sodium at 140. It's not on the lower side. I just read someone said it's on the lower side. It's not on the lower side. It's 140. His potassium is 4.4. It's not low. Urinary volume has been 300 mils. You need to increase the urinary volume so as to avoid further damage to the interstitium of the kidney. For that, the drugs of first choice are loop diuretics. And why have we chosen loop diuretic over a thiazide? Is because the thiazides are usually less effective, or they're totally not working when the creatinine clearance is less than 30 mils, or they have an acute kidney insult. And also they're less effective than loop diuretics for causing diuresis, because of the simple fact that they're less effective. They work on distal tubules. Loop ones work on the loop, and they're more effective. So in this scenario, when the patient has had complete repletion of sodium chloride, has had 3 liters of fluid, is not hypovolemic right now, what we need to focus is increase the urine volume. And for that, the only effective drug would be a furosemide, like a loop diuretic, to increase the urinary volume, right? I hope this is clear now. The furosemide is the right option for this patient. So there have been a lot of drugs that have been studied to consider for acute kidney injury, and we have seen that there is no effect of phenoldiazepam or theophylline or drugs like that to reduce. The only effective drugs have been the loop diuretics, and nothing else seems to work, right? Now, this acute kidney injury thing and all the cases regarding this particular patient have been done. We'll now move forward to the drug-induced nephrotoxicity, if you're ready. So this is a case regarding that. So it's a 67 years old man. He is referred for intermittent chest pain. His medical history is significant for CKD, Kerigo category 3A, right? Type 2 diabetes and hypertension. Medications include enalapril, hydrochlorothiazide, and pioglitazone. Lab values include serum creatinine 1.8, glucose 189, HP is 12, hematocrit 36%. His physical exam is normal. The treatment plan is elective cardiac catheterization, for which obviously he'll be given a contrast, radio contrast for that. So which is the best hydration for a patient who's going through a contrast administration, and followed by that, he'll definitely go through catheterization. Either it's 0.9% sodium chloride or 0.45% sodium chloride or 5 dextrose half saline or oral hydration for this patient. Which is the best option for this patient? Okay, so you guys are already there, Mahanur and Abdul Rashid. You mentioned A, so let's discuss this. So we'll just grossly look at the drug-induced acute tubular necrosis, aminoglycosides. We all know these are the bad drugs for the kidney. So they cause phospholipid accumulation, they cause luminal obstruction. And there is a gradual increase in serum creatinine 6 to 10 days. So regular monitoring of serum creatinine is very important. And whenever there's a large dose, there are concurrent nephrotoxins, there is liver disease along with that, and there's poor nutrition or hypoalbuminemia, the chances of aminoglycoside associated nephrotoxicity are higher. You prevent it by hydration, you limit the dose, you avoid nephrotoxins, and you use once daily dosing. So that's a very important take-home message for aminoglycosides. You can dose it, for instance, with amikacin and gentamicin. You can dose it 3 times a day, or you can dose it once, since they have post-antibiotic effect. So once daily dosing can also work. If you you think the patient is prone to nephrotoxicity, or it's a pediatric patient, always go for a once daily dosing rather than giving it multiple times in a day. The once daily dosing has a lower toxicity profile as compared to a 3 times a day dose. So as a rule of thumb, dose them once. Don't do it 3 times a day. The contrast associated nephrotoxicity is actually a diuresis. These are hyperosmolar compounds. They're low osmolar contrasts and high osmolar contrasts, but all the contrasts are hypertonic. So they basically cause osmotic diuresis, and they cause dehydration as a result of that. And there's direct tubular toxicity because of reactive oxygen species. So the serum creatinine usually rises within 24 hours. 24 hours is the time of assessment. You assess the patient within 24 hours, and it usually peaks within 2 to 5 days after procedure. And in 50% of the cases, you may come across the oliguria also. And the risk factors, obviously, patients who are already prone to hypovolemia, like congestive heart failure, or hypotension patients, or aged patients, like age more than 75, patients who have anemia, patients who are already on nephrotoxins, drugs like amphotericin, drugs like aminoglycosides, like platinum compounds, drugs like other like ACE inhibitors. So these are nephrotoxic compounds. If the patient is already on such kind of compounds and you're given a contrast to the patient, you should be very, very considerate of that because it may worsen, and the chances of nephrotoxicity are really high. We usually consider not giving a contrast if you can do without it. But you see a lot of imaging tests without a contrast, the diagnosis becomes very difficult. So a lot of times contrast administration is inevitable. You need to do that to be able to assess. For instance, in MRIs, for instance, in catheterization case, you need to give the contrast to be able to diagnose and assess and see very clearly. And we prevent that by volume expansion. So the urinary volume pre-24 hours to the contrast administration should be maintained of 150 mils per hour or more, right? And you always choose a low osmolar just to reduce the risk, like iohexol, what are the names? Idohexol, and some the iodine containing contrasts. These are low osmolar contrasts. And you choose them over high osmolarity compounds like gadolinium and stuff like that. And you also discontinue the nephrotoxins if you can do so, right? The treatment for that, there's all the medications that I mentioned, they're all supportive for contrast-induced nephrotoxicity, and nothing is picture perfect to treat the contrast-associated nephrotoxicity. So you can give acetylcysteine 600 milligrams BID starting 24 hours before and 24 hours after. It is an antioxidant, it's a vasodilatory, and helps in reducing the contrast-induced toxicity. Ascorbic acid has also been tested. It's inferior to acetylcysteine, but has been used successfully 3 grams before, 2 grams BID for 3 doses after the procedure. Theophylline or phenoldiazepam, they have no success. So they've been tested, but there has been no benefit of using phenoldiazepam and using theophylline. So what you need to do is have an antioxidant effect with a good drug, like acetylcysteine or ascorbic acid. So choose one of them if you have a choice. And you always hydrate and maintain a high urinary volume to reduce the chance of that. That is the crux of dealing with a contrast-associated nephrotoxicity. Now, the other drugs like cisplatin and amphotericin. So with cisplatin, we have a target drug, amifostine. It is a chelating agent. It scavenges the free radicals which are created by platinum compounds and helps reduce the incidence of nephrotoxicity with the platinum. So you can choose it. You can use it if a cisplatin-induced nephrotoxicity is there. But as a precautionary measure, you always use 1 to 4 liters of hydration within 24 hours of cisplatin administration, just to increase the volume and just wash the radicals out of the body. That is the crux of therapy for that. Amphotericin causes direct proximal and distal tubular toxicity. You limit the cumulative dose to 2 grams. You hydrate the patient with 0.9%, 1 liter before the dose. You avoid nephrotoxins and the liposomal product. You see, internationally, the liposomal products have completely replaced the conventional amphotericin. You never give a conventional amphotericin anymore, anywhere, since we all know it is so nephrotoxic. And you have to use it for a long period of time in a lot of cases, like aspergillosis. You have to use it for a long period of time. And a lot of candidates for amphotericin therapy are pediatrics. And there already are there are high chances of nephrotoxicity in kids, since the kidneys are small as compared to an adult, and the functionality is not as developed as the adults have. So use a liposomal preparation first if you have it available. Please comment if you see it regularly. There in Pakistan, at my time 2 years ago, we could not get it, the liposomal formulation. If it's available now, it is really good. And but the thing is, it's more expensive than the conventional one. So we know that with contrast, this is how there's oxidative stress, there is renal vasoconstriction, there's tubular cell damage. That's how it occurs. And the best way to do is hydrate the patient. So what do you think should be the way of hydration which will expand the volume the most? So which options would you choose for avoiding contrast-associated nephrotoxicity in this patient? Any options? A, Abdul Rashid, Mahnur Rashid, A. Anyone else? Anyone else? Rifat, A, yeah. So you guys are very right. So why wouldn't we choose an oral hydration with water? Oral is like inferior to an IV. It's not going to expand the volume as much. 5% dextrose and 0.45% sodium chloride. So they are hypotonic. The thing with hypoosmolar solutions is that when they're hypoosmolar, that means that they are having a higher water concentration as compared to the solute concentration. And because of the osmolar shift, when you hydrate with a hypoosmolar solution, the fluid actually ends up going inside the cells more as compared to outside in the interstitium and in the vessels, because it's a hypoosmolar solution. So water keeps on shifting inside the cells. So the cells are satiated, but the fluid that you need in the interstitium and in the vessels is not there. So that is why 0.9%, since it's isotonic, it's just like the plasma and the fluid in your body. It is the most preferable fluid for hemodynamic stability and replenishment whenever you choose. Always choose an NS 0.9% unless otherwise directed for some conditions. There are conditions in which we don't choose, but in this patient, we need to increase the plasma. Yeah. So Uzair very rightly said. So isotonic bicarb is also used. So there is an alternative. That's a very good practice associated input, Uzair, that you've given. So the isotonic bicarb can be used as an alternative to 0.9% sodium chloride. If it was available in the options, that could be an option too. But you see, previously, before 2012, there was a presumption that isotonic bicarb is somehow superior to NS. Now, this presumption on the basis of the current studies is just gone. Excuse me. So both of them, bicarb and NS, they're equivalent in their response. So you can choose either of them. It isn't going to impact the clinical outcome of the patient. So you either hydrate with 0.9% sodium chloride, or you hydrate with bicarb. Both of them are going to have the same impact. And you can compare the cost of both of them, and you can see which is more cost effective. So you can choose an NS over bicarb in that scenario. Thank you very much for this input. I really appreciate that. Okay, so 0.9% sodium chloride, as you guys have very well said, should be there. So after administration of radio contrast, which best represents the optimal time to reevaluate the renal function to assess for the development of contrast-associated nephropathy? How soon or how far should you assess? Is it 6 hours? Is it 24 hours? Is it 4 days or 7 days? When should we assess? So it's usually, as we discussed earlier, yeah, Rifat, you're very right. Uzair said, you're very right. The right option is 24 hours. So you assess the patient within 24 hours. 6 hours is too soon. 4 days is too late. You could miss the train. By 4, never leave the patient who's been given a contrast without monitoring. So it should be done. And yeah, you're very right. And Tahira, you're also very right. So 24 hours is the optimum time in which you monitor the renal functions. Very rightly said. So now coming to the functional AKI. ACE inhibitors and ARBs we have just discussed earlier. Also, they cause vasodilation of the efferent arterioles. They can disrupt the glomerular hydrostatic pressure. And as a result of that, they can increase the serum creat and decrease the functionality of the kidney. So usually within 2 to 5 days, there may be a rise of 30%. It stabilizes in 2 to 3 weeks. And congestive heart failure, other toxins, volume depletion, diuretic use, they can worsen the ACE inhibitor associated functional AKI. So what you do is that you titrate the dose gradually. You start with a low dose and titrate it gradually. You initially monitor serum creatinine daily for inpatients and weekly for outpatients. You avoid diuretics and you avoid NSAIDs. That is the best way to prevent ACE inhibitor associated nephrotoxicity. So with the NSAIDs, they're obviously prostaglandin inhibitors. Prostaglandins are vasodilators of the afferent arterioles. NSAIDs would cause vasoconstriction. As a result of that, renal ischemia and toxicity could be there. So what you can do is you can switch an NSAID to another painkiller if it's a possibility. That's the only way to do it. But it's long-term, is usually patients who are taking it for a long period of time, they can develop this toxicity. With cyclosporin and tacrolimus, there is afferent vasoconstriction, renal ischemia, and the best way to do is that you can do TAC levels, you can do cyclosporin levels in the blood and monitor accordingly, and you can use calcium channel blockers to manage that. Okay, so this is just a pictorial presentation of how the NSAIDs cause vasoconstriction and the angiotensin receptor 2 blockers. You see, they're working on the efferent arterioles. So they're causing efferent vasodilation. As a result of that, the glomerular hydrostatic pressure is usually 55 millimeter mercury. It's usually varied. It reduces, causes renal ischemia, oxidative stress, and as a result of that, there could be a damage to the kidney. It's very common. That's why gradual titration is the way to go. Now, there are a few other drugs for which we just need to know what they do and how should we do, what should we do in that case, like penicillins. They can cause allergic interstitial nephritis. So you have to discontinue. For NSAIDs, 6 months into the therapy, they can cause interstitial nephritis. Older population is usually more involved in that. And there have been studies on steroid therapy to manage that, but there's no confirmation that they're totally effective. Now, lithium, when used for a long period of time, can cause chronic interstitial nephritis. So this is also a complication. The good thing with lithium is we can do the levels and just relate to it. So you tend to maintain lower levels of serum, maintain the lithium levels, you avoid dehydration, and you monitor the kidney functions. That's the only way to go about it. So for obstructive nephropathy, now coming to the post-renal disease, the obstructive nephropathy, the most common causes for post-renal obstructive nephropathy is SAMA. SAMA, as you can abbreviate it, like sulfonamides, ascorbic acid, methotrexate, acyclovir, SAMA. Sulfonamides, methotrexate, acyclovir, and ascorbic acid, SAMA. Extrarenal urinary obstruction can be because of anticholinergics, or hemorrhagic cystitis because of cyclophosphamide. So with cyclophosphamide, you usually get bladder toxicity, cystitis, and the scavenger for that is mesna, as you all know. So nephrolithiasis usually is site, sulfadiazine, endenavir, triamterene, and ephedrine derivatives. They can cause nephrolithiasis, renal calculi, renal stones, because of sulfadiazine. These are needle-like crystals that you'll see, endenavir, triamterene, ephedrine derivatives, right? So glomerular disease could be because of a lot of other drugs, NSAIDs, and right? So now this is all with the pre-renal, renal, and the post-renal acute diseases and the functional diseases. Now we are going to move to the chronic kidney disease. This is just a case. The chronic kidney disease is a very common thing, and you get it in a lot of cases, a lot of patients. And the practice pearls are very important when you come to this area of practice. So the first case is, it's a 55 years old man. He has a history of hypertension and newly diagnosed type 2 diabetes. He denies alcohol use, but does smoke cigarettes, 1 pack per day. His medications include atenolol 50 mg per day and a multivitamin. At your pharmacy, his blood pressure is 149/92, 149/92, just remember that. His albumin to creatinine ratio is 400 mg of albumin per gram of creatinine, 400 mg per gram. A recent serum creatinine is 1.9, which is consistent with a value measured 3 months earlier. His estimated GFR is 50 mils per minute per 1.73 meters square. So which category best reflects his kidney disease according to KDIGO criteria? So what we're going to do right now is work on the classification of CKD. So there are two. Kidney Disease Outcomes Quality Initiative. This is KDOQI, right? So yeah, you guys are already given the answer. Oh, grade 4, eGFR. Okay, let's discuss this and then we'll do the answers. Okay, so stages of chronic kidney disease. So according to KDOQI, there are 5 stages, and according to KDIGO, there are 5 stages. They're pretty much similar. The only difference is, the only difference is for KDOQI, there are no further breakup of any stage. It's just 1, 2, 3, 4, 5. But for KDIGO, we have a 3A and a 3B at stage 3. That is the only difference. So 1 is kidney damage with normal GFR, and the GFR is more than or equivalent to 90 mils per minute. 2 is kidney damage with mild decrease, Mild decrease is 60 to 89. Stage 3 is moderate decrease, 30 to 59. 30 to 59. This is for Kidoki, stage 3. Stage 4 is 15 to 29. 15 to 29. Stage 5 is a kidney failure. It's less than 15, right? Or the patient is on dialysis. Any patient who's on dialysis is a Kidoki stage 5. That means he's functionally anuric. This is for Kidoki. Now, Kidigo is a repetition of Kidoki, but just for the breakup at stage 3, grade 3. So grade 1 is 90 or more than 90. Grade 2 is 60 to 89. Grade 3A is 45 to 59. They've further done a breakup of grade 3, which is very understandable since when the creatinine clearance reduces below 45, where it's more than 30, there is a relatively higher chance of complications as compared to a patient who has a creatinine clearance of say 50, 55 versus a patient who has a CRET of 30 to 35. These two patients are not the same. So the complications are higher. So as a rule of thumb, we should go with Kidigo classification since it's more refined in terms of estimating the outcome of the patient and suggesting the therapy. So grade 1 is more than 90 or equivalent to 90. Grade 2 is 60 to 89. Grade 3A is 45 to 59. 3B is 30 to 44. Grade 4 is 15 to 29, as with Kidoki. And grade 5 is less than 15. So coming back to this patient, his estimated GFR is 50 mils per minute. Yeah, Anirudh, you're very right. Anybody else? Sorry. Yeah, anybody else? Zareen? B. Oh, sorry, Anirudh, you gave the answer D. Sorry, I'm missing. Moderate, yeah, you're very right. 3A. Rifat, yeah, 3A. So you guys have assessed it very right. So it's 45. The patient falls in the window of 45 to 59. So it's clearly a grade 3A. Okay. So using the Kidigo categorization, which best assesses this patient's albuminuria. So now we need to study the albuminuria thing. What is the category? So we're looking at albumin to creatinine ratio in the urine. If there is albuminuria, the albumin is being excreted out of the kidney. The higher the excretion, that means there's more proteinuria and the ability of reabsorption of albumin in the body is less. So obviously there's a problem with the kidney and the problem is getting worse. This is a simple explanation of a worse albuminuria. So we don't want our albumin to be excreted out of the body. This is just like a tap that is opened, right? So whenever we used to we used to give albumin, we usually discourage albumin administration for replacement because there's no point. It is a low albumin in the serum, you can see, is just like a smoke out of the chimney, but you don't know why is the smoke being there. So you need to start to close the tap that is filtering out albumin out of the body. So if the kidneys are not reserving any albumin back into the body, no matter how much albumin you keep on giving the patient, is going to end up being hypoalbuminemic since you haven't treated the cause. So albuminuria treatment is very important and managing the kidney functions, improving the kidney condition so that there is less albumin out of the body is very important. Just as a rule of thumb, the ratio of albumin to creatinine less than 30 in milligram per gram, less than 30 is normal to mildly increased, right? If the ratio is 30 to 300, it's moderately increased albuminuria. If the ratio is more than 300, it is a severely increased albuminuria, right? So albumin to creatinine less than 30 is mild, 30 to 300 is moderate, more than 300 is severe albuminuria. So now coming back to this patient, and you have to assess whether it's mild, whether it's moderate, or whether it's severe. Yes, Rifat, C, severe. Anybody else? Anybody thinks it's A2? So his albumin to creatinine is 400 milligrams per gram. It's more than 300, right? So it's a category 3, as Anirudh and Abdul Rashid and Rifat have very well said. So it's a category A3. Okay, so this is how you assess the kidney function, by the GFR and by the albumin to creatinine ratio. So the assessment usually is tricky because all the parameters that we use, like serum creatinine, it's variable with age, with gender, with weight, with muscle mass. Lean patients may overestimate the kidney functions because their muscle mass is less and creatinine production is less, so serum creatinine is less. And as a result of that, you may have a higher value calculated from Cockcroft-Gault formula. So we all know the Cockcroft-Gault formula, right? I guess this is probably one of the first, I don't know the case with mostly with all the clinical pharmacists, this is the first clinical thing that we end up doing, right? We calculate the Cockcroft-Gault formula, estimate the GFR, and adjust the doses of the medications likewise. So, so I guess this is the first thing that most of us do. This is basic. And this gives you the initial satisfaction of doing a clinical thing. I also remember my first clinical tasks was one of these. I calculated a Cockcroft-Gault formula, like creatinine clearance, and then I adjusted the dose of some medication. I guess you guys would also have done the same, or would do the same. So it's 140 minus age into years and ideal body weight divided by serum creatinine into 72. And for women, you usually multiply it with 0.85 since the muscle mass in women is less as compared to males. But the problem with that is obviously it's variable. It is not very consistent. So in patients who have a very erratic renal function, like patients who come with acute kidney injury, or patients who come with the who have an erratic, like sepsis cases who are admitted in ICU, Cockcroft-Gault is very inaccurate. There have been studies on Jalif and Brater and Jalif equation. There have not been enough studies, but that equation is also used for critically ill patients. The other two equations which we use in chronic kidney disease are MDRD, modified dose for renal disease, and chronic kidney disease epidemiology study formula. So MDRD and CKD-EPI formula. These are two other formula. They're complicated. And you can always look at them for the reference unless you're very much in practice with them. The limitations with MDRD is that it's not accurate for a GFR of more than 60 mils per minute. In that case, you always use a CKD-EPI formula. The limitation of CKD-EPI formula is the strength of MDRD. So CKD-EPI is not very accurate at GFR less than 60 mils per minute. So in that case, you use an MDRD formula. Cockcroft-Gault is for general population, not for critically ill, not for CKD patients, not for ICU patients. You see, for ICU, you would hazard a guess at Jalif and Brater equation than a Cockcroft-Gault. For CKD patients, try to use an estimated GFR with MDRD or with CKD-EPI. If the normal GFR before has been 60 mils per minute or more, you choose CKD-EPI. If it's less than 60, choose MDRD, right? So this is how we do that. Now for pediatrics, it's very important. Don't try to simulate a Cockcroft-Gault into pediatric GFR. It's not for the pediatric population. It's a modified Schwartz bedside formula. So you see these things, they're not there in the book. You can just note them down on your chapters. You can just go through this presentation while doing that. So I've just mentioned this formula for reference because a lot of times you're dealing with pediatrics and with their GFR, we have to calculate and adjust the doses likewise. Previously, you used to used to have a K value, and it used to vary for infants and neonates and infants and children from 0.3 to 0.4 to 0.5. But now it's a generalized bedside formula. So the K value is 0.413 for everybody. The height in centimeters divided by serum creatinine. So that's an estimation, that's not exact, but it's an estimation of the pediatric GFR, and that's called the modified Schwartz bedside formula, right? And you can do practice on that by using a number of cases, and you can just calculate it on your own. So assuming the non-pharmacologic approaches have been optimized, now we're dealing with that previous case, okay? We will have patient children. So assuming that non-pharmacologic approaches have been optimized, which is best to limit the progression of his kidney disease? Now, Rifat or Mahnoor, I had a question from for BP, right? There was a question regarding a blood pressure. Rifat, yeah, you asked. Now we are going to touch on these topics now, and this would hopefully answer your question. So we assume that the non-pharmacologic approaches have been done. Now we need to limit the progression of the kidney disease. We need to reduce albuminuria. We need to improve the functionality of the kidney, stop the process of fibrosis. So what should we do? Should we add nifedipine? Should we add diltiazem? Should we add enalapril, or increase the existing atenolol that he's taken for blood pressure? What should we do? Now we'll step into the interesting part of CKD. So diabetic kidney disease, the goal blood pressure in diabetics or non-diabetics. Now I've mentioned a general rule of thumb here. Normal or mild, 140 by 90. Normal or mild, 140 by 90. Moderate to severe, like the albumin to creatinine ratio is 30 to 300 or more than 300. You target strict 130 by 80, right? So 130 by 80 is the target for a patient who's diabetic and whose albumin to creatinine ratio is more than 30. Our patient's albumin to creatinine ratio has been 400, right? I'll jump back to the case after we've done with this detail. So the management of hypertension and proteinuria and CKD, the first line are ACE inhibitors and angiotensin receptor blockers. You use for any degree of proteinuria. You use it even if there is no hypertension and there is proteinuria. A CKD patient who's non-hypertensive but has proteinuria, any grade, you use an ACE inhibitor or an ARB to reduce the proteinuria. It's a drug of first choice. These are the drugs of first choice. Very important. There's a high level of evidence, 1A, a very high level of evidence, right? So, but you hold the potassium is more than 5.6, they call hyperkalemia. You hold if serum creatinine is more than 30% after initiation, because they actually are nephrotoxic also. So with these limitations, ACE and ARBs are the drugs of first choice for hypertension and proteinuria and CKD. And you choose it even if there is no hypertension, though you hardly get a patient like that. But if there is no hypertension and there is proteinuria with CKD, the other choices that can be add-ons are diuretics, thiazides for stage 1 to 3, since we can afford that, loop diuretics stage 4 to 5 for severe cases, loop diuretics. Second line are the calcium channel blockers, the non-dihydropyridine ones. The dihydropyridine types like nifedipine, they worsen proteinuria. There have been conflicting evidence with that. So the non-dihydropyridine ones, they can be considered as a second line if you somehow cannot give an ACE inhibitor or an ARB, right? And the targets for that is HbA1c 7% or less than 7%. Dietary sodium 2.5 grams per day, which means half a teaspoon or less than half a teaspoon. And protein restriction has been studied also for that. Okay. So coming back to the case, assuming that non-pharmacologic approaches have been optimized, which is best to limit? the kidney disease. So for this patient, if we can just go back to this patient and see. So this patient has a blood pressure currently of 149/92. So he has diabetes and his albumin to creatinine ratio is more than 300. His target is strict. His target is 130/80. He is actually hypertensive right now. He needs an antihypertensive also. And his albumin to creatinine ratio is more than 300. He's actually a severe proteinuria case too. So he needs a drug for proteinuria too, which now on the basis of this would be the best option. Yeah, now your options. Option B, Rifat, Uzair. Option C, Rifat. Option A, anybody else? So we start with A, nifedipine. Nifedipine is a dihydropyridine calcium channel blockers. There's conflicting evidence that they can worsen proteinuria, not a good drug. Dihydropyridine calcium channel blockers, if you get a patient with proteinuria and hypertension, try not to use it. It would worsen, it can worsen. There's conflicting evidence that it can worsen proteinuria. So don't choose that. Diltiazem, option B, it can be an add-on therapy and an alternate to the first line. If the first line doesn't work, or if you cannot give a first line, but it's an alternate, it's not the first line. Enalapril is an ACE inhibitor and is the first line. Increasing atenolol probably may reduce the blood pressure, but it would do nothing with the proteinuria. So not a good choice. So as Abdur Rashid, Zair, and everyone else has mentioned, option C is the right option for your patient because it's an ACE inhibitor, it's a drug of first choice. Now, enalapril is added to this patient's regimen. 2 weeks later, he returns for a follow-up. His blood pressure is 139/89. Repeat creatinine is 2.3. And serum potassium is 5.2, which is the best recommendation for this patient. Should you add chlorthalidone? Should you change enalapril to diltiazem? Monitor the blood pressure, change enalapril to valsartan, increase atenolol? What should you do? What do you think should we do? Yeah, any ideas? Change enalapril to the diltiazem, Zareen? Okay, so right now, the only indication for changing or switching or discontinuing an ACE inhibitor is if the serum potassium is more than 5.6 and there is a 30% or more rise in the serum creatinine. If you look at this patient's serum creatinine, it's around a 20% increase. And honestly, you do expect a reversible increase, 10 to 20% increase of serum creatinine with ACE inhibitors and ARBs. There is nothing to worry about. We just keep a watch. But unless it's more than 30%, you don't need to worry. You just keep on hydrating, keep on asking them, drink a lot of fluids and all that. And look at the potassium. If it's 5.2, it's manageable. It's not more than 5.6. So there is no indication for stopping enalapril or switching it to another drug, one over the other. It doesn't make a difference. Both the ARBs and the ACE inhibitors have equivalent impact on the potassium and on serum creatinine. You see, we need to understand these are the drugs of first choice. They're very good for proteinuria. He is a severe proteinuria case. So don't switch or stop it unless it is inevitable. So don't choose any option that's skipping enalapril in this patient because his values are within the normal range. His potassium is 5.2. His CREAT has not raised by more than 20%. Why switch it? But the important thing is the blood pressure right now. His target is 130/80. So what you need to do is add another drug which would reduce, which would cause a diuresis, and along with that will be an add-on therapy to the ACE inhibitor, right? And because of that diuresis, it will help with reducing the potassium levels also. Increasing atenolol is going to have a bad impact on diabetes and a moderate impact on the blood pressure. It's not a very good drug for patients who are diabetic and are hypertensive. Changing to diltiazem, as we already discussed, is not a good option since this patient can take an allopril. Changing to another compound like valsartan, there's no reason for that. So in this case, you're very right, Abdul Rashid, Anirudh, and everybody else, Rifat and everybody. You guys are very right. So option A, add chlorthalidone 50 milligrams per day since he's a grade 3A. So we can use the thiazide diuretics from grade 1 to grade 3. For grade 4 to 5, we'll use a loop diuretic as an add-on. Since the thiazide diuretics do not work at that stage. They're incapacitated at creatinine clearance less than 30 mils. So that is why in this patient, option A is the right option. Okay, this is a question regarding number needed to harm, and I don't think how much time do we have. Aisha, you can just tell me how much time do we have so we can jump to the important, like this is also important, but this is a statistical question. So I'm skipping that. You can just read that afterwards. So KDIGO lipid treatment guidelines say statin. Give us statin. You see, from my experience of reading through the guidelines and doing practice on patients is that for an indication of statin in a patient who's more than 40, the only compelling indication is for that patient to be alive. If that patient is alive, he should receive an aspirin and he should receive a statin. You hardly get any patient who does not have a recommendation for statin. So, and they can be given in transplant patients. They can be given in CKD. The only limitation is that if the patient is going through CKD and it's a dialysis dependent CKD, you do not initiate the therapy. But the patients who are already taking a statin or statin, ezetimibe, you just keep on continuing. Time is 9 to 10. Okay, I'm just going to wrap up with a few more cases. Sorry. So statin, you just continue with statin and ezetimibe. You do not stop the therapy. That's the crux of this. Okay, so a 70-year-old man is being assessed for HD access. So which is the best catheter for hemodialysis? Is it a subclavian catheter, a Tankhoff catheter, or AV graft, or fistula? So in terms of the, now we go into renal replacement therapy. So the indications are obviously AEI, or the valves. It's acidosis, electrolyte abnormality, intoxication, fluid overload. O is for overload, U is for uremia. So these are the indications. There are two primary modes, hemodialysis and peritoneal dialysis. The access, the most preferable one is the natural arteriovenous fistula, which is naturally formed. There are least complications with that. If this does not work out, you can use an AV graft, but definitely that's a synthetic material and the chances of infection are there. And with catheters, the risk of blockade and secondary infections is there. So the first choice in any case is going to be a fistula, arteriovenous fistula. The Tankhoff catheter is for peritoneal dialysis, the subclavian catheter and the graft, they're all inferior. If the fistula doesn't work, you can choose a graft. It is a second line to the fistula. If the graft doesn't work, you can choose a catheter nevertheless. But catheter is really a bad option because of the risk of infections. Now, the complications of renal replacement therapy, the intradialytic hypotension. So the first thing you can do is try a Trendelenburg position, like you can see in this picture. That helps improve the hypotension. You can give saline boluses. You can reduce the ultrafiltration rate. The prevention of that is the midodrine is the most studied drug in this group, in this situation, and orally 2.5 to 10 mg is given. There's conflicting data with steroids like fludrocortisone and SSRIs, but they're inferior to midodrine. Midodrine is a drug of first choice, right? Now in venous access, if there is an infection with Staph aureus, that's very important. You remove the catheter. If there is thrombosis, you try intraluminal altiplase 2 mg or retiplase 0.4 units per lumen, if you can have it. Altiplase has not been available, but It's a very important drug. It should be there. And for cramps, you can use vitamin E. So so this patient is undergoing long-term hemodialysis for intradialytic hypotension. As we have discussed, what is the drug of first choice? Any options? So it is midodrine, alpha-1 agonist, drug of first choice. Sodium chloride tablet is not going to do anything. Steroids and levocannatine, they have conflicting evidence. So for managing intradialytic hypotension, midodrine is the drug. Now, this is a case of peritoneal dialysis associated peritonitis. So this patient has, midodrine, Anirudh, you're very right. So this patient is CKD on peritoneal dialysis with fever and abdominal pain. Her peritoneal dialysate has become cloudy. Culture has been taken, but we have to use empiric therapy. So what therapy will you choose in peritoneal dialysis associated peritonitis? So the common pathogens that we need to target are Staph epi, Staph aureus, Streptococci. Negatives are E. coli and Pseudomonas aeruginosa. You don't need to cover anaerobes. For dialysis associated peritonitis, you need a broad gram-negative and a gram-positive cover. Intraperitoneal administration is preferred for targeted effect of the drug. So you choose a first-generation cephalosporin for gram-positive cover or vancomycin, and you combine it with a third-generation cephalosporin or an aminoglycoside for a gram-negative cover. So a combination of the two. So this is one of the very rare situations in which you can see a first-generation cephalosporin and a third-generation cephalosporin given together. Usually it's not the case, but you can see, as you will see in this case. So for peritoneal dialysis associated peritonitis, what option empirically will you choose? Either it's IV metronidazole plus gentamicin, or intravenous clindamycin and vancomycin, or cefazolin plus ceftazidime intraperitoneally, or vancomycin intraperitoneally. What do you guys think should be the option? Option C, Rifat. Yeah. Anybody else? So with metronidazole and with clindamycin, you'll get an added major anaerobic cover. We don't need that. So don't choose that option. Vancomycin alone is going to miss out on all gram negatives. It's going to miss out on E. coli, Pseudomonas. So don't choose that. So intraperitoneally, cefazolin and ceftazidime. It's a strange medication order, right? Looks very strange, like cefazolin and ceftazidime, both in one prescription. But yes, this can be given because of their spectrum. Okay, so moving on. I guess we can do this. Okay, so jumping to anemia. Anemia workup is very important because you see erythropoietin is produced in kidney. So with chronic kidney disease, you can get reduced erythropoietin levels, and as a result of that, there is anemia. And also because there is reduced iron absorption and malnutrition. So iron deficiency and erythropoietin deficiency associated anemia is very common. So any patient with creatinine clearance less than 60 mL per minute, hemoglobin less than 13 grams per del, in males, or in females 12 grams per del, you need to do the anemia workup. So if it's a stage 3, at least do this workup annually. If it's 4 to 5, at least twice a year. And if it's 5 or dialysis, the workup should be done every 3 months. So the important thing to see here is that you did the retic count. So look at this table, it's very helpful in managing the anemia. So this retic count, iron, total iron binding capacity, ferritin, B12, folate, you've seen all this. If the HB if the iron is less, you give oral or parenteral iron therapy. If the anemia is corrected, you do the maintenance of that. If the hemoglobin in any way is less than 10, you start erythropoietin and the iron therapy, right? And you monitor the hemoglobin every 2 to 4 weeks. If the hemoglobin increase in 2 weeks is more than 1 gram, it's too fast increase, too higher an increase in hemoglobin, you reduce the ESA dose, erythropoietin stimulating agent dose, by 25%. And if the increase in HB is too slow, like it's less than 1 gram per del in 4 weeks. In 4 weeks, it's less than 1 gram. So the ideal thing is in 4 weeks, it should be 2 grams per del increase in the hemoglobin. So if the increase is less than 1 gram in 4 weeks, you increase the ESA dose by 25%. So you monitor the HB every 2 to 4 weeks, and the goal is 11. Any HB above 11, above 10, you don't use an erythropoietin stimulating agent, right? So these are different poitins. They are used subcutaneously, and there's hardly any difference between the two. The darbepoetin and methoxypolyethylene, they are just longer acting ones. Apoetin is relatively shorter acting. You can go through this. So iron replacement orally is not recommended. These patients are malnutritioned. They have decreased iron absorption, and the iron doses required in these patients are very high. So usually we don't go with oral replacement of iron in CKD. Poor iron absorption is, So for adults on hemodialysis, the cumulative of 1 gram is usually used rather than going into the detail of the calculation. We can do the calculation also, but just as a rule of thumb, we go for 1 gram. Transferrin saturation is measured, and ferritin is also measured 3 monthly. So a test dose of iron dextran is to be given. That's an important word. Whenever you have to give iron dextran, a test dose of 25 milligrams should be given before. And with ferric gluconate and iron sucrose, hypotension are the major adverse effects. I've just chosen the important points that need to be remembered. This is the formula for iron deficit calculation. You can just note it from here. And usually we do the iron deficit calculation from this formula, just to remember. Okay, so this patient, actually, I don't want to go to the hyperparathyroidism thing because it would take too much time and detail, and we are already above time. So let's just look at the case and read the case once and do this question. So this is a 6-year-old patient. He has end-stage renal disease. His medications are 14,000 apoetin alpha. He's on atorvastatin 20 mg, insulin, calcium acetate as a phosphate binder, 2 tablets 3 times daily, phenytoin 300 milligrams per day, IV iron 100 milligrams per month. His lab values are HB 10.2. His parathyroid hormone is 800. The upper limit is 65. He's hyperparathyroid. Sodium is 140. Potassium 4.9. Serum creatinine 7. He's a CKD patient. Calcium 9.5. Albumin 2.5. So this patient has a low albumin. So we will need to correct his calcium for the low albumin. And phosphorus is 7.8. The upper limit for phosphorus is 4.5. He's actually hyperphosphatemic. Serum ferritin is 550 and saturation is 32%. His ferritin is okay. His saturation for transferrin is above 30%, which is also okay. The red blood cell count indices are normal. He doesn't have iron deficiency right now. He's just on maintenance. His WBC is normal and he's afebrile. So the most common cause of apoetin resistance in this patient was hyperparathyroidism, but in this patient's hyperparathyroidism is to be managed. So what do we do? Increase calcium acetate, change calcium to sevelamer, whole calcium, or add IV vitamin D analog. So bone mineral density for CKD patients. Calcium and phosphorus for stage 3 should be done every 6 to 12 months. IPTH should be done at baseline. Alkaline phosphate should be done every 12 months. And vitamin D should be done at baseline. These are the important monitoring things we should remember when to monitor. So the calcium for the phosphate binders, the first choice is always a calcium containing binder, but hypercalcemia is an issue with them. And that is the case. Sevelamer is to be chosen only and only when we see hypercalcemia with a calcium containing binder. Lanthanum is like an aluminum binding drug, and ferric can also be chosen. GI adverse effects are there. We should not use aluminum containing binders for long, since aluminum deposits in the bone and can cause adynamic bone disease and also can cause CNS problems. So severe deficiency with vitamin D is less than 5, mild is 5 to 15, and 16 to 30 is just insufficiency. that these are different types of vitamin Ds that are available. And for calcium mimetics, senacalcet increases the sensitivity of receptors to serum calcium. As a drug of first choice, aticalcetide is the alternate, the parenteral alternate to senacalcet, right? So it's an alternate to senacalcet. Senacalcet is the oral option. So this was a patient on dialysis. Okay. So in that case, when we have to choose an option, either we increase calcium acetate, his corrected calcium, which you can see from previous slides, how to calculate the corrected calcium is 10.5, he's hypercalcemic. Or we change calcium acetate to sevelamer and add senacalcet, or hold calcium acetate and IV vitamin D analogs, or add intravenous vitamin D analog. What do you think should we do? So I'll just explain this for explanation reasons. See, if we increase calcium acetate, it's going to worsen the hypercalcemia. So don't do that. Adding vitamin D is not going to do anything. It's going to worsen hypercalcemia, and it's not going to help with the hyperphosphatemia that this patient has. Then holding calcium acetate and adding a vitamin D analog is going to have the same problem. Vitamin D is not going to help with hyperphosphatemia, and it's going to worsen the hypercalcemia. But since this patient is hypercalcemic, but we need to control phosphate, we switch to sevelamer, which is the alternate to calcium acetate for patients who are hypercalcemic. And we add a calcium mimetic senacalcet, which is going to help with the hyperphosphatemia also. And the corrected phenytoin concentration for albumin is usually calculated. So if we just have to calculate the corrected phenytoin level for a patient with low albumin, that would answer this case. So this patient's total phenytoin concentration is 5, and his albumin is 3. So what do you think is the level? So the usual levels for phenytoin are 10 to 20. We need to see if this level is subtherapeutic, therapeutic, toxic, or non-interpretable. So you see, when you see a lab value of phenytoin concentration of 5, you're going to see and think that this patient is subtherapeutic, increased phenytoin dose. But the important thing to see is that patient's albumin. If that patient is, say, a CKD patient or low albumin case or a hepatic patient and has a low albumin, always calculate the corrected phenytoin levels. And the way to calculate the corrected is that you take the level, the measured level of phenytoin, in this case was 5, and you divide it with 0.1 into the serum albumin, which was 3 plus 0.1. So it's 5 divided by 0.4, it's 12.5 mics per mil. So the actual phenytoin level in the body is 12.5 mics per mil. It's a highly protein-bound drug. It's bound to albumin. In cases of low albumins in the body, the drug levels of phenytoin are going to increase, and the corrected level is 12.5. You see, this was a therapeutic level, and we could have misinterpreted as a subtherapeutic level. I guess this is all from my side. I'm sorry to go above the time, and if you guys have any questions, I'm more than happy to answer. Thank you very much.
Thank you so much, ma'am, for sharing your knowledge and giving us your precious time.
Thank you. The honor is mine.
So participants, if you have any queries, you can ask.
Any questions, please? You guys have been excellent participants, and you guys have actively participated. That is more important. I'm actually, I love pharmacotherapy, and pharmacology somehow has been, I really love doing it. And all of us, whoever are doing practice, our patients are a prime concern, and you should always take this as ibadat. I always take it as ibadat. And